Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled The Professional and Technical Divide. This module is targeted to Level 3 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education in the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows. Number 1, to identify the separate professional and technical components of an imaging service for billing and payment purposes. Number 2, to describe the various systems by which Medicare pays for physician professional services and both office and hospital-based technical services. And number 3, to recognize how different payment systems may drive different incentives that are important to managing imaging utilization. We'll be talking more about incentives and utilization management in future modules. Here are some additional resources, listed alphabetically by author, for those who would like to learn more about the topics in this module. I only had one X-ray or one CAT scan. Why did I get 2 bills? It's a question that patients ask pretty frequently to our billing staff here at Emory, and probably yours as well. And it's a question that most radiologists don't realize is even being asked, because most of us don't interact with our revenue teams on a regular basis. But this is more than just a theoretical issue. It's necessary for us to understand how and what patients are paying for their imaging services if we as radiologists are to be real consultants participating in real shared decision-making. And second, it's also important with regard to public relations and professional branding. Think about this for a minute. When do patients first see your name as their radiologist? Is it on the wall in the waiting room, as in some private radiology practices? Or when you introduce yourself to patients as you talk with them on a regular basis? Or when they read your report on your health system's patient portal? I think these are all rather infrequent scenarios. In reality, the first time that most patients see most of our names is when they receive a bill for our services. And they wonder, who is that person I never met? And how come he or she is sending me a bill for these X-ray tests that cost so much? If you've been working through the Replete series with me, this isn't the first time you're hearing about our patients getting 2 bills. You may remember the story I shared with you in a prior module about my daughter getting imaged for appendicitis. It was such a learning experience for her that she gave me permission to share some details. I told you previously that we received 2 bills for her first CT scan. Here are those components on her insurance EOB, that's Explanation of Benefits form. And if you look at these, you can see where she was coming from when she asked me why she got 2 bills for exactly the same thing, a contrast-enhanced CT scan of the abdomen and pelvis with exactly the same CPT code on exactly the same day of service. And the answer is that there were 2 entities providing her 2 very different but nonetheless related services, and they each billed separately. One was for her radiologist, and you see the summary of her bill up top. And the other was for the hospital, and you see the summary of that bill on the bottom. The first is the professional fee, and the second is the technical fee. I mentioned this professional fee versus technical fee divide previously when, in an earlier module, we worked through Medicare's online fee lookup tool. Remember, we focused on global or total fees. That's the top line indicated here. But I said we'd come back later to the professional fee, as indicated here by the 26 modifier, and the technical fee, as indicated by the TC modifier. Well, this is that time. Over the next few minutes, I'd like to help you dissect apart the bills that patients receive for their imaging services. It can be a bit of a puzzle. Let's pull out this piece first. It's the piece of the reimbursement puzzle billed by the radiologist for his or her professional services. It's the top portion of the EOB form I showed you a moment ago for my daughter. and the 26 modifier line I just showed you on the Medicare Physician Fee Schedule lookup tool. Private payers all do things a bit differently, but for this and most other replete modules, we'll focus on Medicare fee-for-service payments because most other payers tend to follow their rules to one degree or another. And for radiology physician professional fees, those services are paid through the Medicare Physician Fee Schedule, MPFS. Again, physician professional fees for most Medicare beneficiaries come from the Medicare Physician Fee Schedule. The bigger part of most imaging services bills, remember, we said previously about 3 times as much on average as professional fees, is the technical component. And that part can be billed by different entities in different ways depending upon where the service was rendered. Those fees go to pay for the scanner and the technologist and the contrast and the IV and the reception desk staff and the scheduling staff and everyone else other than the radiologist who contributes to making those images happen. If those services are provided in a physician office or in most physician-owned imaging centers, those technical fees are paid through the Medicare Physician Fee Schedule, which I'm highlighting again here in gray. And so different services, one professional and one technical, are sometimes paid out of the same bucket of money through the same billing processes. But imaging services are frequently performed in the outpatient hospital or inpatient hospital setting, and that means different buckets of Medicare money. If the services are performed on hospital outpatients, the payments come through a different mechanism, the Hospital Outpatient Prospective Payment System, OPPS. And if the services are performed on hospital inpatients, the payments come through yet a different mechanism, the Inpatient Prospective Payment System. What this all means is that there are 3 payment systems that can be at play when Medicare fee-for-service beneficiaries receive bills for their radiology services. The Medicare Physician Fee Schedule, the Hospital Outpatient Prospective Payment System, and the Inpatient Prospective Payment System. Let's talk about each of them in a bit more detail. We've actually talked about the Medicare Physician Fee Schedule a lot in the many modules leading up to this one. Remember, when we've talked about how prices are structured, I've told you that we were going to focus on how physicians get paid, since that's what is most relevant to most radiologists. The Medicare Physician Fee Schedule, or MPFS as it is sometimes referred, is paid under Medicare Part B. Although there are a lot of nuances, it pays for physician professional fees, such as those to your internist for his or her work seeing you, and to us as radiologists for our interpretive or procedural professional fees. And it also pays for any physician office technical fees, such as an EKG in the office, or a CT or MRI if the imaging facility is owned by a physician group. Fee schedule amounts are based on RVUs and conversion factors, as we have previously discussed in detail in prior modules. And as it currently stands, the Medicare Physician Fee Schedule is nearly fully fee-for-service. That means the more you do, the more you bill, and the more you bill, the more you get paid. So it historically and typically incentivizes physicians to do more. I mentioned HOPS, the Hospital Outpatient Prospective Payment System, briefly in the prior module, where we worked through the Medicare Fee Schedule lookup tool. Remember, over on the right side of that screen that I showed you was a grid that had hospital pricing for the technical component of imaging services. It's the part that I said for a lot of services is higher than what's paid in the physician office setting. Although hospital outpatient payments typically come from Medicare Part B as well, the methodology by which they are derived means that the payments are often different. CMS is working to close this gap as part of what is referred to as a site neutrality payment initiative, but that gap still exists. For HOPS, CPT codes are mapped to groups or families called APCs, Ambulatory Payment Classification Groups, which contain like services. And unlike RVUs that split hairs, APCs typically lump them. And like the Medicare Physician Fee Schedule, HOPS is nearly fully fee-for-service. What does that mean? The more you do, the more you bill. And the more you bill, the more you get paid. So it historically and typically incentivizes hospitals to do more in their outpatient facilities. The payment system that we've not yet talked about is the Hospital Inpatient Prospective Payment System, or IPPS, because inpatient implies hospital. Whereas outpatient services and physician services are paid under Medicare Part B, inpatient hospital services are paid under Part A. Part C, by the way, refers to Medicare Advantage plans or Medicare HMO plans, where Medicare effectively contracts out insurance to private companies. And Part D refers to the Medicare prescription plan. But that's all an aside. As we'll talk about some more in the bundled payment module coming up, hospitals are paid for inpatient services based on some 700 some DRGs, or diagnosis-related groups. One of the most common DRGs is for elective knee and hip replacements. There are other DRGs for sepsis and CHF and COPD and pretty much everything else that you can imagine. And most of these have DRGs to differentiate more versus less complex patients. For each DRG, the hospital essentially gets a fixed bucket of money that is determined based upon the average episode of care. So if a patient can be discharged in 3 days, the hospital still typically gets the same payment as if that patient were discharged in 5 days. And if a patient got 3 chest x-rays or 5 chest x-rays during that hospitalization, the hospital still gets paid the same. So there's an incentive for hospitals for their inpatients to use fewer services, very different from fee-for-service. We'll talk about this some more when we talk about bundled payments and related opportunities for radiologists under new physician payment models. The common thread here is that regardless of how the technical fee is paid, there's always a professional component for the radiologist's work. That's your work. The technical fee is typically paid separately, and it may come from the Medicare physician fee schedule and go to the providing physician's office based upon its RVU weighting, or from the hospital outpatient prospective payment system and go to the hospital for its outpatient services based upon the assigned APC, or from the inpatient prospective payment system and go to the hospital for its inpatient services based upon the assigned diagnosis-related group. Again, one professional payment and one technical payment, which varies depending upon the site of service. Let's put these pieces back together with a few quick examples that you see listed here. Let's start first with the scenario of a Medicare beneficiary who has her, say, screening mammogram or brain MRI at a private radiology group's imaging center. There's a professional component, remember, the 26 modifier amount, and a technical component, remember, the TC modifier amount. Since the radiologist and the group are one and the same, there is typically, though, just one bill, called a global bill, since it reflects both the professional and technical components billed globally. And so in this circumstance, the patient could get 2 bills, one for each, but frequently just gets one combined global bill. How about the scenario where a radiology group provides interpretation services for a non-radiology group that owns imaging equipment? This happens not uncommonly with orthopedic surgery and neurology and neurosurgery practices. In this circumstance, there are typically 2 bills, both from the Medicare physician fee schedule. The radiologist bills for his or her professional services, and the clinical group bills separately for its technical services. But sometimes, and more commonly for private insurance than Medicare, those 2 practices enter into a different arrangement. In this situation, the clinical practice bills globally and then pays the radiology group directly at fair market value for their professional services. In this situation, patients will only see one bill. But in this circumstance, those patients may think that their orthopedist or neurosurgeon has interpreted their images. How about the hospital outpatient setting? Here again, there's a bill from the radiology group for their professional services, and the bill for the technical services comes from the hospital and gets paid by Medicare through its hospital outpatient prospective payment system. Even for employed physicians like me, there are 2 bills, one from our clinic corporation and another through our hospital corporation. And the scenario is essentially the same for inpatient services. Here again, there's a bill from the radiology group for its professional services, but the bill for technical services comes from the hospital and gets paid by Medicare through its inpatient prospective payment system. But in this circumstance, the hospital doesn't get paid per click for its imaging services, but rather gets a single bucket of dollars, regardless of whether the episode within a given DRG used a lot of imaging or just a little bit. So in summary, most radiology services result in the generation of two bills, one professional and one technical. For Medicare, physician professional and physician office technical fees are paid through the Medicare Physician Fee Schedule. Hospital outpatient and hospital inpatient technical services, in contrast, are paid through respective prospective payment systems. Understanding how imaging services get paid will help radiologists become more valuable as consultants to their referring physicians and to their patients as they help those individuals navigate the imaging portion of our healthcare delivery system. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the REPLETE initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.